Thanks, Connor. Really appreciate the privilege of the podium. I have the following disclosures, none of which are relevant to the talk. So this is a not too uncommon scenario that we were faced with. Get called, 27-year-old male with ulcerative colitis who comes in, admitted to GI in medicine and has bloody bowel movements and abdominal pain. Otherwise healthy, really no medical problems, fairly fit, smokes a little bit, had no prior surgeries. And by the way, when I walk in and tell him I'm a surgeon, he says, hey, I don't need you. There's no way that I'm going to have surgery, and I will do anything. You can give me any medication you want to. I'm not having surgery. No problem. He's thin. Physical examination, initially soft. He's got the generalized tenderness of palpation, according to his UC that he has. And this you can see kind of his initial hospital course. He actually does well, and I round him the next day, and I said, you know what? I tell you what. I know you're doing well. I know you're going to do anything to avoid surgery, but just in case, what I'd like to do is I'm going to have somebody else come and visit you that might not be too great for somebody who's a 27-year-old otherwise healthy kid, and that's an enterostomal therapist. And just in case you do bad and your colon is bad, we're going to mark you ahead of time and see from there. And so he's like, you can do whatever you want to do because I'm not having surgery and I'm not going to need that person, so it really doesn't matter. So GI scoped him, and you can see here from the scope that he had mild to moderate colitis in some areas, and some areas were actually a little bit more severe. So on the morning of discharge, I get a call at about 5 in the morning, and all of a sudden now you can see that he's not doing as well. Fever's to 103, tachycardia, white blood cell count is now elevated, and he's got a significant increase in his tenderness that my resident tells me about, and he's on his way up. Medicine got a CAT scan, and now he's got some thickening and fluid in his pelvis. Transverse colon is dilated and thickened, and by the way, he's got pneumatosis in his bowel wall throughout the thing. So the question comes up, how many people in the room would take this patient laparoscopically to the operating room? And for those people, how many people open, just a standard open? So roughly about half. So for those people who would do it laparoscopically, the question then comes, are you going to do this hand assist, or and then you're going to do it open? And there's more to that, because the issues that go through my mind in this particular one are several-fold. First of all, is it feasible to do whatever the operation you're doing laparoscopically? And then, am I benefiting the patient from doing a laparoscopic approach? Is there a downside to this? And ultimately, where does this lie in the future? And I think these are the questions we have to ask ourselves when we're talking about doing an emergency colectomy. And what I'm not going to talk about today is the issue about laparoscopic drainage and lavage and the things like that. We're talking about colectomy type operations. And so along with this, we have to think to ourselves, we're doing a colon operation, and what goes into that in terms of what is our port placements, what is our extraction sites, and how does that relate to somebody like this that might need an ileostomy, and where are we going to place that, and are we going to need to make that ileostomy site one of our port placements? And so all of this comes into fruition, and so obviously postoperatively we have to take a look and see what is the specimen that we're going to have to get out here, and what is the shape of the colon that we're going to get into. So I had a video here, and I can tell you that this was the original talk uploaded. My video's not popping up. So while we work on that, for sure in laparoscopic colectomy, there's been reported benefits that we all know of. Less pain, shorter return of bowel function, everything like that. But there's also been some negative sides to it. For sure, even though they're kind of merging nowadays in terms of the operative time, that with more and more experience, the operative between open and laparoscopy tend to be equal. There is definitely a higher intraoperative complication rate. And what is the cost associated with this? And probably more important to this particular talk is, do these same benefits carry over to emergent type setting? So I'm going to take a look at the data a little bit about laparoscopic emergent settings. And there's different conditions that we do emergent operations for, and one of them is obviously inflammatory. Interesting, there's not a whole lot in the literature that's specifically replaced in terms of emergent type surgery. In this particular paper, it was a NISQIP evaluation. You can see about 1,100 patients, and overall the complication rate was in univariate analysis was significantly less with laparoscopy than it was with open. And, but by multivariate analysis, you see that they had similar morbidity and mortality when they case matched these particular patients. So is the cup half empty, or is the cup half full? It's interesting to see the way that the authors decided to do their conclusion. And what they said is that a laparoscopic approach for Hartmann procedure, you see right there, does not significantly decrease postoperative morbidity or mortality in comparison with the open technique. A way that you could look at this is saying, well, maybe we're not giving our patients a benefit, even though in univariate analysis it was that case. So a very small series that looked at perforated diverticulitis and basically took a look at a Hartmann's procedure and then what are the benefits of that going forward in terms of saying, I'm going to take care of them by basically doing a washout. All of these particular cases were straight laparoscopically with none of them having any complications at all. And then all of those patients in 2 to 3 months down the road successfully undergoing a laparoscopic takedown. And the author said in this particular study that it's not only the benefits that you get at that time, but it enables you to potentially do a laparoscopic takedown in the future that potentially you couldn't do using a straight to an open approach. In right-sided diverticulitis, again, very similar. Estimated blood loss is similar between those. Return of bowel function is better. So some of the same things that we are seeing in the elective type setting, again, with complication rate being significantly decreased in the laparoscopic approach versus the open approach. So in the elective setting, when bowel function returns earlier, when blood loss is later, that again, it's not too surprising, or maybe it is surprising in some people's mind that we're seeing those same benefits in an emergent type setting. What about obstructive type disease? Well, in large bowel obstruction, one of this particular paper that was out of Taiwan took a look at 22 patients, and what they said is that we can use this particular approach versus stenting, or if stenting is not available, by taking them initially for a laparoscopic colectomy and then eventually having a stoma takedown, and you can see very good results associated with these particular ones. And all of these patients initially got in a diverting colostomy, and then afterwards they went there. So if you don't have stenting available, potentially this will provide some benefits in this situation. Again, another one for a large bowel obstruction of various type of things, whether it be from diverticulitis and stricture or whether it's from cancer. And you can see all of these particular patients underwent anterior sections, Hartmann's or right, all various procedures. And again, the operative time, a little over 90 minutes. The conversion rate was very low. Length of stay was low, complications and leak, all respectable outcomes when you take a look at this particular paper. And you have to take a look and realize that in many of these cases, the colon is what it is. In a large bowel obstruction, very dilated, they're unprepped. And so when you look at these outcomes, you got to think about in terms of that. But what about the patients that we don't want to necessarily just divert and bring up an ostomy, which many people say, okay, I can deal with that, but what about restoring our in-continuity type management? This particular paper took a look at, again, NISQIP type evaluation. In multivariate analysis, laparoscopic had longer operative times and a shorter length of stay, and overall, they had similar morbidity and mortality after case match. And if we can compare the outcomes in that previous study that kind of emphasized the fact that laparoscopy did not decrease any of the ones, these particular papers chose to look at it a little bit differently. They said it does indeed have postoperative morbidity and mortality rates that were comparable, and they chose to emphasize the positive a little bit, that it does reduce the hospital and postoperative length of stay. So we took a look in our series at similar NISQIP, and we decided to say, let's not only, it really depends a lot in terms of what particular type procedure we're doing, because definitely in this particular case, for ulcerative colitis, whether you do a partial colectomy or total abdominal colectomy or a pouch or any one of these really has a different one. And you can see here that about 7% of these particular cases are emergent type operations. And what we found in multivariate analysis is that essentially is that laparoscopy, whether you looked at it in the emergent setting or whether you looked at it in the elective setting, was associated with a decreased complication rate overall on multivariate analysis, and as well as an overall low rate of mortality, but again, decreased mortality significantly associated with laparoscopy. For volvulus, it's been looked at as well. As a matter of fact, it's first described back in 1991 in one of the first case series of laparoscopy, and laparoscopic colectomy alone had some volvulus cases in it. Now, it's important to look in this particular literature that there's various techniques, whether you use a lap assisted, just a mobilization and bring it out, or whether you do everything intracorporally. Overall, when you look at these small case series, we see low morbidity and mortality, and there's really a lack of data outside of case reports and series, but definitely there is an emerging role. So when you look through the literature, I think a couple of things get pointed out. First of all, that very low numbers are still out there, anywhere in kind of the case series type ones, but it is used on a lot of different disease processes, and within those disease processes, we see that there's various different procedures that are done, anywhere from a partial colectomy all the way to a total abdominal colectomy to restorative type operations. And overall, the outcomes in general are either similar or better, with only one study showing that it was worse. So what are the barriers of laparoscopic use? Well, I think you have to take a look and say, you know, how sick is your patient? What's the severity of the disease? What is your patient selection? Is it going to be somebody that you're going to want to tackle, as Rick said, somebody who's morbidly obese with a BMI of 50, in addition to having a sick colon at that particular time? And will they be able to tolerate the steep Trendelenburg that we might need in laparoscopy? And then what is your experience of the operation? And, you know, and that depends in large part, what is the site of the disease and what are we dealing with? What is your experience? And also, what is the experience of the team? There's nothing more frustrating than to be able to get in there and, for me, dealing with residents, if I'm operating and my resident is looking at the anterior abdominal wall the entire case, it makes for a very frustrating afternoon. Or conversely, if I'm running the camera and I'm looking at the anterior abdominal wall and they're looking at something else, it can be very frustrating to go. So many of you may say, can't I just stick a scope in and just convert if need be the case? Well, what's the impact of conversion on these particular patients? It's important that you take a look and see, are we talking about an emergent situation, or are we talking about elective situation? Because if you look at the elective data out there, in this particular case, it's probably one of the ones that is the largest out there. Conversion rate was associated with worse outcomes across the board. Didn't matter if you looked at leak rate, wound infection, ileus obstruction, UTI, so that many of you may say, well, that's harmful to my patients and I'm not necessarily going to do that. So how often do we convert? Large study that took a look at this, and you can see in general conversion rates have been, over the last about 3 to 5 years, have been pretty consistently right around 15 to 20%. It is interesting when you look at this paper that laparoscopy use in an urgent setting is still, despite that conversion rate, is still being performed in an urgent setting, again, around 17 to 18% every year. So if somebody comes in and they undergo a colectomy, about 15 to 20% of the time, they will be taken to the operating room and undergo a laparoscopic colectomy. This particular paper was very interesting. They stratified outcomes, again, in the emergent setting in terms of conversion rates, which that other paper said that they do worse. So they tried to stratify it and said, we're going to look at severity of illness, and we're going to do it by whether it was minor severity, major severity, or those patients that had extreme severity. And what you see in the data is that you see, if you divide this in terms of laparoscopy, a conversion rate, or those that are open, if you look at the mortality, the morbidity, the length of stay, or the readmission rate, that whether it's laparoscopic or conversion, either one of those cases are significantly improved compared to open type surgery. So maybe in the urgent type surgery, if you have to convert in those patients, and whether it's stratified by, again, minor illness, by major illness, or by extreme illness, in each of those scenarios, that if you're able to start it laparoscopically in the urgent type setting, and even if you have to convert, in general, they do better than with open type surgery. So I can envision an algorithm for you that goes something like this. The first case comes in is that, do they have a need for urgent colectomy? If so, let's resuscitate them, let's give them IV antibiotics, make sure they have DVT prophylaxis, do all the things medically that we have to do. Then we take a look, and the next question we ask is, do they have a contradiction to laparoscopy? And if that answer is no, then we're going to take them to the operating room, we're going to put a scope in and explore. And you have to ask yourself in that case, is this one going to be better that we do straight versus hand assist? And then you have to be honest with yourself and say, is this a case that I'm just going to mobilize only? Perhaps on a left-sided one, I'm going to take down the splenic flexure and I can avoid them the large morbidity of an open operation, or am I going to be able to resect and divert? And if so, if things aren't going well, if I'm doing straight laparoscopy, can I convert that to a hand assist, or do I have to convert that to open? So looking back on the questions that we asked before, is it feasible? Are the outcomes approved? Is there a downside? And what is the future? My answers to those questions today is it feasible? Absolutely. From personal experience and from experience provided in the literature, it is absolutely feasible to be able to do. Are the outcomes improved? Yes, some of them are. There's no question that length of stay is improved, that return of bowel function. And the morbidity and the mortality in general on some of the larger series is improved. And in some cases, they've shown that is at best equivalent to an open procedure. Is there a downside? Well, it depends. If you don't have the technical expertise to be able to do this, then you can harm your patients. And if you're unaware of that, and you proceed forward, there's nothing worse than slogging through a 9-10-hour operation when what you really had to do is get the patient just off the operating room table and get them resuscitated. And is it the future? I think almost assuredly. I can tell you that my residents' skills these days, I worry sometimes about their ability to do an open operation, much less do a laparoscopic approach. So thank you very much for the privilege of the podium.
Thank you, Scott. And I'd like to introduce my co-chairman, Connor, who's well known to you all, to talk about integrating perioperative care pathways with laparoscopic colorectal surgery.
Thank you, Roger. So maybe not the most exciting topic, certainly after some of the great talks we've just heard. But I think this is important for how we look at overall resource utilization. And if you look at the way healthcare financing is going, I think around the world, but particularly in this country, resources are something we're going to have to manage more and more efficiently. These are my disclosures, none of which relate to what we're discussing here. So we do have continued reduction in the resources available to us, whether it's beds or staffing. We're getting continuous reductions in reimbursement. As we know with sequestration recently and reductions in cost from the government, if you're doing 40% Medicare in your hospital, that's 1% off your bottom line. Most hospitals in the US run on a 1 to 3% margin. So that may be their margin gone just as of a couple of weeks ago. So reimbursement continues to trend down in absolute and also in more subtle ways. And while costs in many situations are going up, training I'm not going to go into. Now the airline industry has been used as an analogy for healthcare and probably overused. I'm not sure the car industry is a perfect analogy either, but I think it's probably better in that we see patients going through, we build different models of car and do different operations, and maybe no two cars are the same. Everyone has a different color or slightly different finishing. And you see that whether you look at results within a hospital, looking at one physician or one group of surgeons, or internationally, and these are data from Henrik Kalot within multinational survey. And you can see the variability in length of stay after colon resection from 7.8 days in hospital or 7 days after surgery in the US to 10 or 13 days in different countries in Europe. And if you were to put Japan up on the screen, it would be in the 20s. So culture is one of the things that is involved. Now industry, led by Toyota and the concept of Six Sigma, has got at standardization of process and reduction of variability, such that Six Sigma is where everything is an acceptable product, meaning in the center of this graph, except anything outside the sixth standard deviation. So that's a fraction of a point of a percent. In healthcare, often, and perhaps particularly for colorectal surgery, we're probably at about a half sigma, with a lot of variability and 30% complication rates depending on how you define them. So what causes this variability? Well, there are some things we have no control over. I mentioned length of stay in Japan. National culture is something that is practically impossible to control and will certainly take a generational shift to improve it. Practice profile, case mix, oftentimes patients come through the door. We can't do much about that. We have some control over the operating facility. You choose where you work. You have some choice over the equipment that you get to use, and you have more choice and more ability to influence the team that you work with. We have most control as surgeons over the perioperative care plans that we use and over the surgical techniques that we use. So when you look at length of stay as a metric for quality and resource utilization, one of the primary things that drives that for us as GI surgeons is postoperative ileus. And while we understand a lot about the pathology, we don't really know what ticks it off in some particular patient. Some patients will have an extensive abdominal operation and recover very quickly, and sometimes every now and again you'll do an easy, straightforward case and they have a very slow recovery. This is some work from Tony Bauer, who's a basic scientist at University of Pittsburgh who has an interest in this. And this just shows the complexity of the inflammatory and biological pathways involved in postoperative ileus and why no one drug or no one process is going to fix it. It's as complex as any inflammatory pathway. So this is something Henrik Kalett and I and Tony Senegor worked on quite a long time ago now, and we put together a consensus group and came up with some definitions and some suggested management pathways. And we've also been able to work on some medications that may help. This is an interesting data set which we published on a while ago, and this is from a pooled group of control patients in a series of randomized controlled trials. And these are all open colectomies. So the simplest thing that we do, open segmental colectomy. And you can see their time to recovery with the percentages of patients that had nausea, obviously early postoperative nausea, and vomiting are common. And then if you look at, we defined it for this study as GI2, which was meaning tolerance of diet and passage of stool. If you look at GI2 recovery, which is the red figure, you can see that the median is about day 4, and that was trailed about 24 hours later by discharge at about day 5 with a mean close to day 6. And so this is open segmental colectomy, the simplest thing that we do. And actually for a multi-center trial, because this was across a lot of hospitals, these are not bad numbers and outcomes. And we had a fairly standardized postoperative care plan. But even though these are the easy cases, hopefully doing well, you can see that about 12% were readmitted to hospital. 13% had a hospital stay over a week, meaning that fully a quarter of patients had something that none of us, if we were the patient, would think of as a perfect postoperative result. So Henrik and Linda Bassa, who's one of his colleagues in Denmark, have obviously published extensively on this, and this is one of a series of papers that they've published. And they've compared a conventional local district general hospital in this paper to their multimodal academic medical center. Now their volumes are low, it's only 40 colon resections a year, so less than 1 a week on this service, and so that's obviously easier to have resources to look after, but the results were impressive. Patients moved their bowels earlier, they had a short length of stay whether you look at mean or median, and this is the shortest mean length of stay in the literature after open colectomy. Complication rates lower but defined slightly differently. Leak rates a little high perhaps, but consistent between both. But the readmission rate is a real problem, and this was one of the things that drove Henrik to redefine his goal for discharge, because the readmission rate of 20% is certainly an outlier for us in the US and would be an outlier for Medicare, and is much, much higher than most of the international literature. So I thought I'd show you some of our experience with this, and this is some of our early work looking at enhanced recovery pathways done in late 99 and got published about a year or so later. And this is a consecutive series of 60 open cases, and this was done very much to match Henrik's first paper, which came out a couple of months before, with 60 open cases. And a lot of IBD, hence the younger age than one might expect. But more than half of these were having pelvic surgery, not just simple colectomies. And in fact, more than half of them had had a previous major laparotomy, such as this fellow with Crohn's. And still, with the standardized care pathway, we were able to get a mean hospital stay of about 4.3 days, which short of Henrik's 3.3 day paper was the same as his initial paper and the same as several papers that came into the literature around that time. So standardized care pathways, you can hit around 4.3 to 4.5 days for open for at least certain populations of patients. And our readmission rate was pretty respectable at about 7%. We applied this then to a lot of different types of patients. This is just one of many papers. Yehuda Kareev was the first author, and we looked at 100 ilioanal pouches compared to traditional care pathways. And whether you looked at mean or median stay, we took about a day off length of stay. Readmission rates were similar, and yes, it's higher. This has actually been published on once since then. Again, proctocolectomy with ilioanal anastomosis does tend to have a slightly higher readmission rate. But you see that we also took a little more than 10% off cost, and that can also be a fairly significant reduction. We studied it with a few randomized controlled trials, and it tends to be that it takes a day off length of stay, particularly if surgeons are experienced with these pathways, and the patients aren't disadvantaged. Their pain scores going home are the same. Their satisfaction, if you measure it on a Likert scale, is the same, and the readmission rate did not tend to be any higher. At least in our hands, epidurals didn't help. Length of stay stayed at about 5 days in this randomized trial, whether patients had a PCA or an epidural. And actually, if you look at the meta-analysis and you look at the literature, while epidurals, if they're opioid-free, and that's an important point, epidurals can accelerate time to GI recovery. They actually don't shorten hospital stay. Readmission rates, which is the fear of many when they start using these pathways, that their readmission rates will bounce up. Well, it tends not to be the case, whichever paper you look at, and there are more since then, and this is one meta-analysis looking at this group. So we talked yesterday and somewhat today, but particularly yesterday, about standardizing operative technique, and so how does laparoscopy fit in? Well, so we and others have published on different pathways, but it's a combination of preoperative information, perioperative standardization, and then early diet. So patients eat the day after surgery, they get oral medicines the day after surgery, any tubes or catheters would come out the day after surgery, and you set them up for an early discharge. This is a kind of consensus report that we put together, and Michel Adamino, when he was working with me, worked on this, and again Henrik participated in this, and we combined it with a meta-analysis, and it pooled some of the data that I'm going to show you. And so what we were able to do when we combined laparoscopy was drop about half our length of stay off open cases, and this is older data from about 10 years ago. Again, I mentioned to you dropping about 10% off our cost structure. And so when we put that into a department where we were doing a few hundred cases a quarter, you can see that these fast-track care pathways cut about 40% off the hospital bed utilization, but when you combined it with laparoscopy, it cut about 60% off the bed utilization. So now, when we combine laparoscopy and open over a large number of patients, we've got an average stay 4 days or less, and it changes a little bit depending on the population of patients, whether you look at a low anterior or totals. Totals tend to stay a little longer. So more recently then, and this is actually the first year after I moved to Case Western, the first 120 cases, we had a length of stay of 3.7 days, and you can see that very few use skilled nursing or home care, because that's obviously one way that you can accelerate patients getting out, which may not be appropriate. And what you also see is that the patients who went home within 48 hours of surgery had the lowest use of skilled nursing and home care. And they also had the lowest readmission rate, so 8.5% for the whole population. The patients who went home in the first 48 hours, 5%, and the patients who stayed 4 days or more, about 14%. So we've done this for many things as well, and this is an older paper looking at laparoscopic resection, and Rafael Lincetmo is in the audience, spent some time with me and put this paper together. And you can see that for these proctectomies, and this was just my cases at the time, we were able to get a length of stay, a mean length of stay of about 3 days. Again, Tony and I looked to see could epidurals help us for the laparoscopic cases, and it didn't. We were hitting around 2.5 days at that stage. This was more colectomies than proctectomies, and hence the length of stay is a little bit shorter. But epidurals didn't help us. So are there other things that we can add to the process? Well, there was a little discussion about it yesterday, but this is a paper where we pooled early experience. Antonio participated in this, and Harry Papaconstantino, and Deb Nagel and I, and we put our experience together with single port to see if that would help. And certainly you can do it, and you can do it through stomocytes and all of those other things, and Dan showed some nice data yesterday. But certainly at that stage, it didn't significantly change any of our length of stay, and we have found the same since that time and published on it. We've looked at local anesthetics. Can local anesthetics be used? And this is a comparative series we did looking at either no local anesthetic into the wound, or local anesthetic into the wound and intraperitoneally, and there were no significant difference between groups. What's been most interesting recently is the use of TAP blocks, or transversus abdominis plane blocks, which we now do under laparoscopic control. And so this is a comparative series, and actually this is in press now, and there's a couple of other papers we have going through on this. But you can see the mean hospital stay, and this is for a case match series, the mean hospital stay was 3.2 days, and this includes colon and rectal resections, with about not too many going home on day 1, only 4%, and 19% on day 2, very similar to that older paper I showed you from 2008. Well, using TAP blocks and actually oral Tylenol at high dose in combination with the TAP blocks, we've dropped our mean length of stay down to about 2.1 days. And when you look at a very large series, it's actually about 2.4. So it's been quite consistent with a median length of stay of 2 days. And you can see that now a third of my patients would go home the day after surgery, another third would go home 2 days after surgery, and the remainder would go home 3 or more days after surgery. And obviously the patients with the stomas tend to be in this day 3+ group. But getting an overall hospital stay of around 2.5 days. So by combining all these different things in an additive manner, we can achieve fairly reproducible results. Debbie Keller is working with me at the moment, and this is a paper we've submitted to DCNR looking at process control. So again, industrial type methodology to look at process and variability in outcome. And you can see the addition of the TAP block has reduced the variability in these two control chart analysis of patients prior to TAP blocks and since TAP blocks. So I'd conclude by suggesting that by combining perioperative care pathways with laparoscopy, we can do the safest and most cost-efficient surgery. I think we can truly only realize the potential of laparoscopy when we do use it in combination with standardized care pathways and enhanced recovery pathways. And I think we have the opportunity to standardize care between institutions, centers, and internationally, and as part of that, develop new standards for care and new standards for safe discharge. I'll finish with a slide just showing next year's meeting. And if any of you are interested, we have a desk out front for the International Society. And if you go, you can either be emailed information about membership. And we'd love you to join us in Paris next year in June when we're having the next meeting of the Society. Thank you very much.